Good afternoon. My name is Natasha Oyedele, and I want to welcome you to the NIH Office of Disease Prevention's Method Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar by clicking on the question mark in the WebEx toolbar. Please direct your questions to all panelists. We will open the floor to questions that have been submitted via WebEx at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap in approximately 1 week. You will receive an email when they are available. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be prompted to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Natasha. Today's speaker is Dr. Klasnja. Dr. Klasnja is an assistant professor in the School of Information at the University of Michigan and a scientific investigator at the Kaiser Permanente Washington Health Research Institute. He works at the intersection of human-computer interaction and behavioral science, and he studies how mobile technologies can help individuals make and sustain lifestyle changes needed to improve their health. He's particularly interested in the design and evaluation of just-in-time adaptive interventions, technologies that continuously adapt their functioning to provide optimal support to individuals as their needs and circumstances change during the trial. It's my pleasure to welcome Dr. Klasnja.
Thank you for the introduction, Dr. Murray, and thank you all for participating in today's webinar. As many of you probably know, this is the third in the series of the Mind the Gap webinars dealing with intervention optimization, the area of work that Linda Collins has pioneered around using different kinds of experimental methods to allow us to make better decisions about how to design behavioral interventions. And just so we're on the same page, I just want to make sure that we are thinking about the optimization studies in the same way. And really, when we talk about optimization studies, we are talking about studies that have the goal of gathering evidence that can inform decisions about how to improve an intervention. So the idea is to come up with a set of success criteria that are intended to allow you to have a sense of whether you're doing better works in relation to an intervention. And this usually has to do with both effectiveness or efficacy criteria, as well as the various kinds of constraints like cost or burden, duration, and so on that a particular intervention has to meet, and then conduct a study that would allow you to generate evidence that can then be used to inform how the intervention needs to be changed in order to meet these optimization criteria to create as best of an intervention as you can create given the constraints that are placed on that intervention. So optimization is really about studies that help you make decisions about how to improve an intervention, not studies that are intended to evaluate an intervention package in its current form. And I think this is really key to understand, because micro-randomized trials that we'll be talking about today have that flavor as well. So just to frame a little bit about micro-randomized trials, let's compare them to how optimization is done via factorial experiments, which is how optimization trials have been traditionally done. So with standard factorial experiments, the goal of these studies is to help generate evidence that can inform the selection of interventions that are included in the package. So you have a set of interventions that you're considering including, and then you conduct a study that will evaluate whether each individual component within those components that you're considering it has a promising effect of some sort that will justify inclusion in a package. And then you, based on what you're finding, you make decisions about which intervention components to include and which ones to leave aside, whether because they're too expensive, whether they're because they're ineffective, or because they interact with other components in a package in a way that is not productive. So we do typically do this by estimating main effects for individual components, and then looking at two-way interactions between components, and potentially looking at also moderation by baseline factors, things like whether particular intervention components work better for men versus women. And so all of this allows us then to have evidence that can help inform the decision about which components to include and which ones not. With micro-randomized trials, we're doing something similar in respect to mobile health interventions, but there are a couple of differences which is what we want to be covering today. One is micro-randomized trials are an experimental method that is explicitly intended to help you make these kinds of optimization decisions around what we're typically calling push intervention components. And so really the way to think about these is that they're components that the system is delivering to individuals based on some set of system rules. So these are things like reminders, like motivational messages, things of that sort, right? And so the system has a set of rules that are referred to as decision rules that allow the system to try to provide these interventions to individuals at the times that are most appropriate for receiving the interventions. And so what micro-randomized trials allow you to do is to make decisions about which of these push components you want to include, as well as determine what the right decision rules are for those components to make them work as best as you can. And this is the second piece that is different than how traditional factorial designs work. So not only are you trying to make selection of components, but you're trying to determine decision rules for these components. As well as and you will see an example of that a little bit later on today, you are able to make some decisions about how a particular push component needs to be designed. And I think this is one of the reasons why micro-randomized trials can be really important and really useful in the process of developing effective mobile health interventions. So really, when you put those things together, what we get is that micro-randomized trials are able to both help you optimize an intervention package as a whole, right, by choosing components, and this is very similar to how factorial designs work, as well as allow you to actually optimize individual components by refining decision rules and the component design. And so you can gather evidence both that will be applicable to the whole package, as well as the decisions that need to be made about individual components. And in the rest of the webinar, I want to tell you about how we're going to be doing this. Just to step back a little bit, though, before we will dive into micro-randomized trials, I think it's really useful to think about what the larger scientific objectives behind all of this are. And so in addition to just building better interventions, building better tools, I think one of the big promises of micro-randomized trials, and why I'm particularly excited about them, is that they allow us to create evidence that I think is a lot more easily usable and easily by other projects, so that it can be taken up more easily by other researchers and in future projects to inform decisions about what components to use and how to design those components to increase the effectiveness of our interventions. Furthermore, and you will also see a little bit of this in my presentation later on today, is that some of these methods are allowing us to start to understand how our interventions are working in the real world. We're starting to get glimpses of the underlying mechanisms that are being actuated when we provide the interventions that are contained in mobile health intervention packages. And this allows us to better understand how human behavior is working, which I think is really, really promising. So without further ado, let's dive into micro-randomized trials and try to understand what these things are and how they work. So just to start, when are micro-randomized trials useful? And they're useful in particular in two scenarios. One is when optimization questions have to do with the push components. So they're components that you're trying to include in your mobile health intervention that are going to be automatically delivered by the intervention to individuals. And a archetypal example of this is something like a medication reminder. So if you have, for example, a intervention for medication adherence in the case of, let's say, hypertension, and individuals are intended to be taking the drug once a day, you can have the systems send automatic reminders once a day to remind them to take the drugs. But any of the things that we send via things like push notifications or text messages are also push components. So motivational messaging, various kinds of coping strategies that we send in for example, addiction interventions. All of those kinds of interventions can be optimized using mobile micro-randomized trials. The other thing is that is really relevant to whether a micro-randomized trial would be a useful method for you. It has to do with the dynamics of the behavior that is being targeted, and the places where micro-randomized trials are particularly useful are where an individual component can have measurable near-term impact on the health behavior that is being targeted. So things like physical activity, mood, sleep, adherence are all examples where you can imagine where even a single dose, a single delivery of a particular intervention component could potentially have some kind of impact. That is a really key requirement for making micro-randomized trials work, and you will see in a second why that is the case. So what are micro-randomized trials? So and how do they work? In a nutshell, you can think of it as really involving a three-step process. The core of micro-randomized trial is the sense that every time a particular push intervention component can be delivered, so at each decision point where your system may be able to deliver an intervention component, during the trial, one would randomize whether that component is delivered or not. And so the randomization is done at every decision point for the intervention components under study. And at each one of those randomizations, you would try to capture a proximal outcome for that randomized component. So as well as the contextual factors, things like location, the state of the person, let's say whether they're stressed or not, and so on, that may influence whether they are responding to this component or not. And then with the data that is collected from this kind of trial, you're able to model the component's causal effects, the treatment effects, both averaging over the course of the study, as well as looking at time-varying effects, how the effect changes over time, as well as how those effects are moderated both by baseline characteristics, things like sex and so on, as well as by the time-varying factors, the context in which, for example, the component is delivered. And I will go in detail about each one of these individual pieces. So let's start with the decision points, because this is really a key piece that makes micro-randomized trials different than a lot of the other kinds of designs. And what we mean by a decision point is really the times when an intervention component is appropriate, when it might be a good time to deliver it. And this will vary based on the dynamics of the target behavior, the level of the activity of interest. So, for example, how stressed the person is, or something of that sort, as well as the user context. So it might be that in some situations you suspect you might want to deliver a component, while in others you don't think it's a good idea to do that. And so as a simplest example, again going back to our blood pressure medicine adherence issue, a decision point for a component a reminder component to help someone adhere to a hypertensive medication would be every day. So once a day, you would have an opportunity to send that reminder and remind the person to do it. But the times don't have to be fixed. So another way to do decision points is based on the level of a behavior. So as another example, let's say you're trying to create an intervention to help people reduce their sedentary time. In this particular case, it might be that after someone has been sitting for a certain amount of time, let's say 40 minutes, that is the thing that triggers the decision point, and you might decide that that's the time a reminder to get up and stretch one's legs is appropriate. So in this case, it's really the level of the sedentary behavior, in my example, 40 minutes, that would determine when the decision point is reached. So it's not a fixed time, it's the level of behavior, it's based on the level of the behavior. The other key piece of micro-randomized trials is this notion of a proximal outcome. And really the way to think about proximal outcomes is that they're most immediate intended effects of a single dose of the intervention that you're trying to study. And what I mean by those can vary, right? It could be, in the case of a reminder, just a single reminder. right? Like we had in the case of our anti-sedentary messages, right? So a single reminder pops up, and there is an appropriate outcome that reminder is intended to accomplish. In this case, whether the person gets up, right? That's what that reminder is supposed to affect. But the dose could also be different. It does not need to be a single delivery of a particular component. It could be that, for example, you have a set of motivational messages that are intended to help someone increase their self-efficacy for, let's say, physical activity. And you think that given how slowly self-efficacy can move, that it really takes it's a week worth of these messages, maybe let's say 3 messages over the course of the week, is what would be needed in order to see any kind of a noticeable change in self-efficacy. In that particular case, really that what you would be thinking of as the dose of the component would be a week worth of messages, and your proximal outcome would be outcome at the level of the week. So it might be that then at the end of the week you have some kind of a self-report measure that looks at the self-efficacy, and that becomes the proximal outcome for the full week worth of messages. So in this particular case, the dose is defined as a particular unit of messages, in our case a week, and the proximal outcome is matched to that dose. So that it's assessed at the same with the same kind of time dynamics as the dose of the intervention. And really, the way to think about proximal outcomes is that they're mediators of the more distant health outcomes that you're trying to accomplish. So if we have something like a prompt to walk, for that we send to a person if we're trying to increase their physical activity, then sort of the proximal outcomes of that individual prompt might be first some kind of increased readiness to walk as a psychological outcome, and then as a behavioral outcome, a near-term number of steps that they take over the course of some period of time after the prompt is delivered. In this case, let's say 30 minutes. And it's really that short behavioral outcome that then feeds to a larger behavioral outcome of steps a day, for example, that then leads further to national guidelines and cardiovascular fitness and so on. So really that they're mediators that are directly impacted by a particular intervention component that then are leading down the path towards the distal outcomes that we are trying to affect. And finally, this notion of contextual moderators is really key to micro-randomized trials. And this has to do with the fact that these kinds of push intervention components do not work the same in all circumstances. And so in the case of this anti-sedentary messages example that we've been covering, if you're thinking about something like a grant deadline and you're in the middle of writing a grant, you're trying to submit it, and your computer pops up a little reminder telling you to get up and walk around a little bit, you're probably going to be far less receptive than if you're just having some downtime and you're browsing the web and the same reminder pops up. So the context in which that particular kind of intervention is received can be hugely influential on whether the intervention is effective or not. And so with micro-randomized trials, we try to capture that by capturing all of the contextual information that happens at the time of the randomization that we think might influence whether a particular person or the population as a whole is responsive to that intervention component or not. And so let's talk a little bit about my randomization. Randomization micro-randomized trials again happens at each decision point when a particular intervention component can be delivered. But what that means is that during a study, a particular person might be randomized many times. So with a once a day reminder to take a hypertensive drug, for example, if you have a 30-day study, for each individual person, randomization would happen 30 times. And depending on how many people you have, the total number of randomizations could be quite high. In the case of intraday intervention components, like the activity suggestions that I'll be discussing in my example a little bit down further on, that number can be even substantially higher. So you could have hundreds and often thousands of randomizations that happen within the single study. The other piece that's important to note is that multiple components can be randomized concurrently in a single micro-randomized trial. So you could have multiple components that they can have very different decision points and very different dynamics that all would be randomized based on their own set of decision points concurrently as part of the trial, which basically makes micro-randomized trials a form of the factorial design. So they're a sequential full factorial design where each of the components is randomized based on its own set of decision rules. And why would you want to do that? Well, there are a few things that we can learn from micro-randomized trials that make them particularly useful in service of optimizing mobile health interventions. One is, like with traditional factorial designs, you're able to assess whether a particular component has a proximal main effect, right? So in this particular case, you're getting some sense of, is this thing doing anything at all, right? Is there some signal here that this particular component may be useful? You can, but also, given that these randomizations are happening sequentially over the course of the study, you can start looking at the dynamics of that changes over time. You can see how it's moderated by contextual factors like location or the weather. As well as you can take a look at whether a particular intervention component is having some kinds of delayed or lagged effects. So you can see how those effects are changing over time and whether the effect is persisting beyond the immediate future when you're first assessing the proximal effect. And so what that allows you to do then is to get really deep understanding of the dynamics of your intervention in order to make choices about whether to include it in your intervention package, and if so, how that particular intervention should work. The other thing to note, and you will see an example of this in a little bit as well, is that given that that randomization happens within person, MRTs are a highly efficient design because they're taking advantage both of the within-person contrast. So for a single person, the times when they were randomized to receive a particular intervention versus when they were randomized not to receive that intervention, as well as between-person contrast. What that means is that you're able to do studies that are fully powered with only a small number of participants, and we will see an example of that as well. So what I want to do then for the rest of this webinar is give you a concrete example of what this ends up looking like. So you get a sense of exactly the kinds of things that you're able to learn with a micro-randomized trial. And for this, I will be using a system called HeartSteps that my colleagues and I have been developing over the last few years that was intended to help individuals become more physically active. And in particular, what we're going to be looking at is the very first version of this HeartSteps system that was intended to help sedentary adults to increase their physical activity throughout the day, mostly through walking. And what we did is we conducted a micro-randomized trial to both try to understand two of the components that we were considering, what we needed to do with them to make them more effective, as well as to trial this method and see that we can pull it off. The first version of HeartSteps had two push intervention components. That it had actionable contextually aware activity suggestions, as well as a component that was helping individuals plan when, where, and how they're going to be active on the following day. The activity suggestions were based on this notion of a cue to action, where we really wanted to have something that we can send to individuals to help them get more activity throughout the day by making it more easier for them to come up with ideas of what they may be able to do right now in their current situation in order to be active. And so we had a large library of about 500 messages that we created that were tailored on a number of contextual characteristics. So they were tailored on the time of the day, whether it was the weekday versus weekend, the person's location. So we knew whether they were at home versus at work versus at some other place, as well as the current weather. Since we had people's location, we were able to get the current weather. And then we would send a person a message that was tailored to that combination of contextual factors to give them an idea of there's something they would be able to do right now. And you see on the screen one example of what those kinds of messages look like. And they were sent as push notifications. But we also had two different kinds of suggestions. One were just suggestions to go for a walk. And what we were targeting is something like a 10-minute walk to get someone to do about 1,000 steps was what we were hoping these suggestions would be able to do. But at the same time, there are just so many ways you can ask people how to walk, and we were afraid that these suggestions might get boring. So we also included another type of suggestions to help individuals just disrupt sedentary behavior, because we could make those much more interesting and entertaining. And so in relation to activity suggestions, we had a number of questions about this intervention component. We wanted to know, does actually providing a suggestion using these kinds of push notifications help an individual increase in activity shortly after that activity suggestion is delivered? So does it do anything at all? We were looking for just signal on, are these things going to be helpful? And then, if so, we wanted to more deeply understand how that intervention component would work. Does its effects change over time? Are there differences in how these walk-in suggestions work versus the anti-sedentary suggestions? And then we wanted to know, are there any differences around how well they work when you deliver them in different locations, or at different times of the day, or whether there are any differences based on the weather outside, for example. And finally, we were interested in does the dose of the suggestions matter? Like, we all get a lot of push notifications, and we wanted to get a sense of what's the right number of these things that we should be sending to people to maximize their effectiveness. For planning, the planning intervention component was based on this notion of implementation intentions that Peter Govitzer and his colleagues have been working on for a number of years, which is really this concept, and I'm sure most of you are familiar with it, that when individuals make highly specific plans, and when they plan when, where, and how they're going to be active or conduct another kind of activity, they're much more likely to actually do it. And so the lab literature on implementation intentions is quite robust. So we wanted to see, can we actually do this to help individuals be active over time? So we wanted to include this component, but there was a design issue here that we were trying to consider. Normally, when social psychologists do studies with implementation intentions, they just have a person write down on a piece of paper a plan for how they're going to do the behavior that they're planning to do. So let's say when, where, and how they're going to go and do a mammogram. And so we wanted to have a high theoretical fidelity version of this component. And what you see on the left here is basically a digitalized version of just that kind of a plan. So we give people a text box, we give them an example of what kind of plans that the specificity of the plans that they should be writing, and we ask them to write a plan. But since most of our lives are pretty routinized, right, and we end up doing the same things over and over and over again, we thought that maybe we could just help individuals reduce the burden of planning by providing them with a list of plans that they had previously made. And so for the other design, we wanted to see if we just give them a list of plans that they had made, and we initially seeded this plan with some relatively sensible things that most of us do in our daily lives. They would be able to just select a plan instead of write it from scratch, and that might work just as well, but without quite as much effort. So we were interested in seeing both whether these plans work in order to help individuals increase their activity, as well as whether it mattered whether we used an open-ended planning like it's typically done in the lab, or we provide a little bit of support for that through a screen like what you see on the right here. And again, so in terms of optimization questions for this component, we wanted to know, does it work? So do we get a signal that this kind of intervention component is going to be useful? And then how their effects might change over time, as well as then whether there are any differences between open-ended and this kind of choosing a plan from a list interfaces. So what we did is to answer these questions, we ran a 6-week study with 42 sedentary adults, and we micro-randomized both the activity suggestions as well as the planning components. What you may note about this is that it's a very small number of people. We have 6 weeks and 42 adults, so individuals. For the activity suggestions, we were fully powered to detect an effect for this component. And that's what I mean by the fact that micro-randomized trials can be highly efficient. So this is a very small study. It's a kind of a study that we typically think of as a pilot. But in the context of micro-randomized trials, it can actually be a fully powered study for the components that you're trying to randomize. So that's the efficiency is a really sort of key piece of this particular trial design. And so how did we randomize activity suggestions? On any given day, there were 5 decision times when individuals may be able to receive these suggestions. And this was based on some data that these 5 times a day are when individuals have a lot of intraperson variability in their activity, so which might suggest that they have a lot of opportunity to be more active. So this was around morning commute, around lunchtime, mid-afternoon, around the afternoon commute, and then after dinner. And each individual was able to set exactly for themselves what those times were. And then for on each day of the study, for each individual, at each one of these 5 decision points, we randomized whether we sent activity suggestions with the following scheme. At 40%, we didn't send the suggestion at all. And then for the remaining 60%, we split it 50-50, whether we would send someone a walk-in suggestion or we would send them an anti-sedentary suggestions. And what's important to note here is that we only sent walk-in activity suggestions if a person was available for treatment, which meant that they were not already walking, so we did not want to bother people if they were already being active, or we did not send a suggestion if the person was detected to be in a vehicle, so they might be driving and we did not want to distract them. So we would try to prioritize safety and not burdening people with unnecessary suggestions, and we will only render when those two conditions were met. They were not currently walking and not in a vehicle. In terms of the proximal outcome, again, these activity suggestions were intended to act as cue to action. They were really intended to help someone get some activity very shortly after that activity suggestion was delivered. So we chose a 30-minute step count following the randomization as our proximal outcome. This is what we thought would help us assess whether these activity suggestions were useful. And our rationale for this was that a much longer window might be too noisy, right? So we might not be able to see an effect, especially for something like anti-sedentary suggestions. We often just ask people to move around a little bit, like stretch or go to the water cooler or something like that, where if you had a much longer time window, those steps that were accomplished through that suggestion might be a very small part, and they would be overwhelmed by noise. But on the other hand, we also wanted to account for the fact that sometimes when you send someone a notification, they don't see it immediately. So we wanted to have a time window that was long enough to still capture an effect if someone did not see the suggestion as soon as it arrived. The one problem with this kind of an outcome, and you will see this with any proximal outcome you choose, is that there are always trade-offs, is that it doesn't capture state-to-stand transitions. So for anti-sedentary suggestions in particular, if someone was just sitting when they received it and they just stood up and for a period of time, we would not be able to capture that with our outcome. And then, so for at each one of the decision points, we collected a whole lot of information. We collected the step count before and after the randomization. We collected the response to the suggestion. The interface for sending these notifications allowed a person to select whether that they liked or didn't like that suggestion, or if it came at the wrong time, as well as a lot of contextual information that we thought might be informative. So the person's location, the weather, time of the day, and so on. For planning, we did something similar. The planning was randomized every night, so it was done daily, unlike the activity suggestions. And we randomized them with 50% chance of receiving planning. So half of the time people were not being asked to plan. And then if we asked them to plan, we randomized 50-50 whether we would ask them to create a new plan, or they could choose from a list of previously made plans. And here again, we needed to decide on a proximal outcome. And here we decided that really what we are after is the whole step count on the following day. And we wanted to see whether the overall activity on the following day got increased. And what's nice about this outcome is that it captures changes in plans. So if someone planned to do one thing, but they ended up doing something different, that would still count towards that would still count as the credit for making the plan. As well as that it's really well aligned with the desired distal outcome. We wanted to overall increase people's activity, and we get at that through looking at the whole day step count. The problem, of course, is that it only captures step-based activities. So if someone decides plan to go swimming and they actually go swimming, we will not be able to see that because the job on up monitor that we were using to track activity was not able to detect it. And then with planning as well, we captured information at each randomization time. We captured the step count. We captured the weather on the following day, so we had a forecast for the next day, as well as the day of the week, the day in the study, and amount of time spent on the planning screen. And you will see in a second why that piece is important. So to get a sense of what kind of analysis you do with micro-randomized trials, all of this is done using a method called center and weighted least square method that was developed by Susan Murphy and her collaborators. And really, these are regressions that are very similar in flavor to something like GEE or linear generalized models, where they're hierarchical models where each the data points are nested within person, and for each one of them, what's important about these methods is that the treatment indicator for a particular intervention component is centered around the probability at which that particular component was delivered. So in our case, for the activity suggestions, what you see here is 0.6, is that the 60% chance of receiving the suggestion was a fixed probability throughout the whole study, and so that the treatment indicator is centered around that. But you can then also do things like you can interact the treatment indicator with different kinds of contextual factors that you care to investigate. In our case, one of the analyses we pre-specified was this looking at how the treatment changes with time. So you could interact it with, in this case, the date in the study. So this is clearly not real math. These are just conceptual models. But this particular citation here, Borovka et al. 2017, has all of the statistical details of how these centered and weighted least square methods work, and in order to do the analysis of micro-randomized trials. So what did we find? For activity suggestions, if we just looked at all of the suggestions that we delivered over the course of the study, there was a little bit of a marginally significant effect that we could increase the 30-minute step count post-randomization. And this wasn't a very large effect. We only added about 12% to the 253 step average that during this period after each randomization. So not particularly interesting, right? What gets interesting is once we start looking at all of the other kinds of analyses that we did. So if we just look at the start of the study, the effect was much higher. We would add 167 steps at the start of the study, but then that effect got smaller over time. And over a month, there was basically nothing left. After a month, the effect for this particular component completely disappeared. But then we could also separate the walk-in suggestions and anti-sedentary suggestions. And here we start seeing something quite different. For walk-in suggestions, there's a much larger effect, even if you would just marginalize over the whole study. But we didn't see anything for the anti-sedentary messages in this particular case. And that remains the case even if we look at the time trend of the effect. So for walking suggestions alone, at the start of the study, we were adding an extra 271 step. So that's over 120% increase over the average at the start of the study. But that particular component as well the effect would decrease over time and disappear after a month. But for anti-sedentary messages, there was absolutely nothing. None of the anti-sedentary messages were registering as doing anything on this proximal outcome that we chose, the 30-minute step count after the time of the randomization. So we're able to see, as you can see just from these few pieces of data, that we could get some information both about how these different types of suggestions worked, as well as how that effect changed over time. And I'll be coming back to that. There are a few other interesting things around activity suggestions. One is that the dose over the last few days was negatively correlated with the one's ability to respond to the next suggestion. So the more suggestions we provided over the last 3 days or 5 days, the less likely a person was to respond and walk after we send them another suggestion. So this is a really nice example of the fact that people are just habituating, right? And so it's our suspicion, especially based on what we were hearing in the interviews, that this decrease over time is just the fact that people get tired of this intervention. And we're able to see that even with just looking at the response based on the dose of previously received interventions. The other thing is that the activity suggestions didn't work the same regardless of where the person was. In particular, if we sent them when someone was neither at home nor at work, so if they were at some other place, we didn't get any effect at all. So the only effect was coming when the person was either at home or at work, when we had really good information where the person was, and we could make those activity suggestions highly tailored to that particular context. If they were somewhere else, if they were at a park or if they were at a coffee shop or whatnot, we just didn't know how to do the tailoring on the context very well, and our data indicated those suggestions did not work nearly as well. But the other thing that was interesting is that anti-sedentary suggestions, even though they were not working in terms of our proximal outcome, were much preferred by individuals when we actually interviewed them, because they were a lot more interesting. So they liked receiving them. We just didn't see any kind of outcome on the proximal effect that we chose. So what did we do with this? And this is I think a key piece of how micro-randomized trials can be useful for helping you make optimization decisions. Well, since walk-in suggestions were initially very active, we decided to keep that component. But we also decided to keep the anti-sedentary suggestions because people really, really liked them. And they kept telling us this in interviews, is that these were their favorite kinds of suggestions that they received. But given that we decided to keep them, we needed to make some decisions about how to change how these components are delivered. For anti-sedentary suggestions, we decided to change how the suggestions are delivered, but to really much better target sedentary time. So we changed the decision points. Instead of providing them on these 5 times during the day, we actually now are providing anti-sedentary suggestions based on the prolonged sitting time. Our new sensors are able to detect that, and we can actually make these anti-sedentary suggestions much more timely. The other thing is that we really wanted to deal with burden or with that habituation. So we basically are strongly decreasing the probability of sending suggestions when someone is at another location, when they're not at home or at work, as well as that we're taking the dose of the suggestions that we're sending strongly into account, and we reduce the probability whenever we start providing too many messages. So all of the data that it shows you ended up being directly used to make decisions about how to optimize this component in the next version of HeartSteps. For planning, we had a similar situation, and I will very quickly just go through this. There was nothing really interesting when we looked at both times of planning together. We really didn't see an effect when we averaged over the course of the study. Where things got interesting is when we started actually looking at the unstructured and the structured planning separately. For the open-ended planning, we actually had an effect we ended up providing 523 extra steps when the person was when they received open-ended planning versus no planning, and that p-value should actually be there should be a 0 there. So it's again sort of marginally significant, while the structured planning was not doing anything at all. And this became even stronger when we started looking at contextual moderation. So, for example, on weekdays, planning worked. But on weekends, it didn't do anything at all. And one of the reasons for this, we think, is that sedentary adults, at least what they were telling us in the interviews, is we're looking at physical activity as work, and they really didn't want to be bothered over the week on weekends with doing this. But the other interesting thing is that so if we look at open-ended planning just on weekdays, the effect is actually quite large. We get nearly 1,000 extra steps just for this one individual component, but only on weekdays. Again, there was absolutely no effect on weekends. But what was also interesting is that there was no significant interaction with the day in study. So this is the first mobile health intervention that I'm aware of that I have had any experience with, where the effect stayed actually relatively constant over time. It did not decrease with time as it did with the activity suggestions. And this tells us a couple of interesting things. One is, it seems like the user interface, the decisions that we made with planning actually made a significant difference. And it seems that just the attention of having to write a new plan is doing something to include these plans in a way that is not accomplished when you just quickly choose something from a list. And it's maybe that attention really that is driving the stability of the effect as well. That if enough attention is paid, the components that are really requiring that kind of attention are not going to deteriorate at the same rate as something that is absorbed a lot more passively, like the activity suggestions that we were providing. and participants reported that the planning was too frequent, and that they don't really think of planning as a daily activity rather than as a weekly thing. So here as well, we could actually use this information to make changes to our system. So we try to balance the need for attention with burden, and we now have a structured form that still requires some attention, and it requires the person to be thoughtful about how, the time that they will spend exercising, when it's going to happen, what the activity is going to be, but without actually asking them to write a new plan from scratch. And we made this a weekly component to account for the fact that it was too frequent in the first study. So just stepping back. So what did we actually learn from this, and what does this mean for micro-randomized trials? What you see here is that what we had is a very small, inexpensive study that provided a whole lot of data about both how these two individual components need to function, right? So we got information both about their temporal dynamics, we got information about their design, we got information about the need to deal with habituation, as well as some interesting information about what might be happening in terms of the mechanisms that are being activated with these interventions. In particular, this notion that planning requires attention, that it is only effective when the person is spending enough attention to write the plan or to think thoughtfully about the plan, is really, really interesting and really intriguing, that I would like to follow up and look at that in more detail. So as well as that, the rate of habituation to messaging interventions is another piece of information about the actual dynamics of the underlying mechanisms that I think we need to take seriously into account. So what does that all of that mean from MRTs? Well, it means that you're able to generate evidence that very directly informs the decisions you make about how your intervention should work. So that makes it allows you to efficiently test multiple push components. You can look at both the questions around whether a particular component should be included, as well as how that component should be included. So it will inform your decision rules, as well as potentially inform your decisions about how it should how it should be designed, the user experience aspects of this, like we did in the case of planning. As well as that, it allows you to actually start accumulating evidence about the conditions and boundaries of the effectiveness of individual components. So in what situations these components work, when do they not work? Not only for whom, like we have been doing with baseline moderation for a long time, but also very specific information about the context in which these components work. And this will allow us potentially to start coming up with a set of components that can be reused across studies, that is then paired with the evidence for when those components are most likely to be effective, so that the researchers can make informed decisions about what to include in their next project. Also, but it's also important to know that my MRTs are not always useful. And in particular, so if your optimization questions are really dealing with pull components, so things like psychoeducational content or things that you just include in the application for individuals to access at will, those kinds of components cannot be studied using the micro-randomized trial design. You can study them in other ways, but this is not the design for you. As well as that, if the decision points are occurring very infrequently, so for example, if you're trying to provide some kind of just-in-time support for, let's say, suicide attempts, right? These are things that only happen very rarely. Micro-randomized trials are not the way to study these interventions. And finally, if the outcome that is being targeted is only moving very, very slowly, so you're not likely to get at outcomes that are closely tied to an individual delivery of a component or some like a week worth of delivery, then micro-randomized trials are not the right design. And finally, as you've seen, that our key requirement to micro-randomized trials is that proximal outcome can be measured after each randomization. So if you're not able to do that, then this is not the right design. There's still a lot of times when this is the design that can be highly helpful, but for many kinds of mobile health interventions, micro-randomized trials will not be useful, and it's important to keep that in mind. So I will stop there so we can have some time for questions, but thank you so much for your attention.
Thanks very much. Very interesting presentation. And we have questions coming in from the audience. So let's get right into them. Sort of a general question to start with. How do micro-randomized trials fit in with other optimization methods like MOST or SMART trials or other kinds of? Can you tell us when you would use this approach as opposed to one of the others?
Absolutely. So you should think of micro-randomized trials as just another experimental design that can be used as part of the MOST framework. And you would use it in the optimization stage. So you would use it at the first stage of the design. And you would use this method when you have some individual intervention components that are push components that you're trying to optimize. Now, you can combine MRTs with other designs. In particular, I have done a study recently where I have a factorial design where we do some baseline randomization on a different intervention component that does not have this kind of a sort of repeated delivery nature. And then for the push components, we micro-randomized those components sequentially. So you're able to combine micro-randomized trials with factorial designs, and this can often be a highly efficient way to try to study more complex. And you can actually even combine it with SMART as well, although I think that is likely to be less common. Now, SMART, of course, are used to optimize adaptive interventions where the decision points for making changes to the intervention are much more spread out. So often you would be looking at something like response status after a month or after 3 months, and then deciding how to change the intervention, whether to what other component to provide. While for micro-randomized trials, really the frequency of these decision points, trying to have interventions that are much more timely to the dynamics of the behavior that's what they're best suited for.
We have a couple of questions that are similar. One, are there pilot studies that would be helpful before you launch the MRT? And if so, what kind? And second, would doing MRTs iteratively be helpful? So you've done one, you have the results. Is it worth doing another one, and under what conditions?
Yeah, so really good questions. I actually think of micro-randomized trials as something that can very feasibly be included in a pilot study. To actually make a pilot study give you a lot more information than it typically would. In fact, we did something very much like that in a study that we ran at Kaiser last year, where we had this physical activity intervention for patients after bariatric surgery, and we wanted to just do a feasibility pilot to see is this something that has some legs. But then we included a micro-randomized trial for a couple of components as part of that pilot, because with the kinds of the numbers of people that we typically include in a pilot, you can often actually be powered to see effects for the components that are micro-randomized. In terms of sequential micro-randomized trials, yes, I mean, optimization is a process that is intended to be continuous, right? And so what we're in fact for HeartSteps doing a second set of micro-randomized trials right now, where we're both micro-randomizing some additional components that were not there in the first version, as well as we're trying to see whether these changes that we made to the components that I just discussed are changing how those components are going to be effective. So it's absolutely feasible and often scientifically interesting to have multiple micro-randomized trials run one after another. And you might want to do that until you actually have something that you think is robust enough and you feel good about that you would want to do a confirmatory trial in a standard RCT.
We have a question from a listener where the context of the listeners or the questioner's organization plays a big role, probably asking whether IRB review is required for this kind of study. And I would presume if the person is working at a university or college, the answer is absolutely yes.
Absolutely yes. That's exactly right.
If they're working for Google or someone, it may be a quite different answer.
That's exactly right. Yeah, I'm not sure I have anything to add to that. It's a standard user study with human participation. So it would be governed by the same kind of considerations as any other human studies.
Right. If you're generating generalizable knowledge, it requires IRB review.
It's research. Absolutely.
A technical question or a statistical question. You showed us some regression equations. I think that was the only algebra today. And you said that the method relied on centering. Can you tell us what the centering does?
Yeah. And so the paper that I put on the slide will give you more information. But effectively, what the centering does is that it makes the treatment orthogonal to the parts of the model that are just dealing with noise reduction covariates. Well, basically, what it allows you to do, and Susan Murphy and her collaborators can answer this in more detail. I'm not a statistician by training by any means, but what centering does is that basically it allows you to misspecify covariates in the model and still get a unbiased estimate of the treatment effect. And so that's its main purpose. The other thing that it does is that it allows you to do that even when the probability of providing the component is changing over time. And there are a number of studies where you might not have fixed probabilities, but the probability would be based on the current level of the behavior. And so for let's say if you have a component that's trying to help with stress, for different individuals, the amount of time that their stress will vary, and so you might want to actually have a predictor of stress that is directing the probability with which those interventions would be delivered. And so for at each decision point, that the actual probability would be different at which the treatment is delivered. As long as those probabilities are tracked, then the treatment is going to be centered by them in the analysis, and you will still get an unbiased estimate of the treatment effect.
What characteristics make a good proximal outcome?
Yes. So the first one is that it needs to be measurable, right? And so you want to have an outcome that you're able to measure after every randomization. The other piece is that really, for this trial to be useful, the proximal outcome needs to be on something where you're going to have enough variability over the kinds of time scales at which these intervention components are operating. So that's why I was saying if you have a slower moving outcome, something like, let's say, self-efficacy, it might make sense to actually measure it weekly and then think of the component that is influencing it as being a weekly component, in which case they would get randomized at the weekly level. So you might have weeks when you provide, let's say, motivational messages versus weeks when you don't provide motivational messages. But the idea is to have the proximal outcome have enough variability at that time scale so that you're actually able to capture whether your intervention is doing something. But the fact that it needs to be measurable and it needs to be measurable in a way that is not highly burdensome is really key. So if you require really burdensome self-report every time you're trying to assess the proximal outcome, that's probably not the right kind of thing to use in a micro-randomized trial.
Have you found that there are specific tools that are very helpful in either running the micro-randomized trial or conducting the analysis?
Well, so all of the libraries, the statistical libraries that Professor Murphy and her students have written for this are running in R currently. So R can be used to do all of the analysis standardly, and they're basically just additional packages that are used on top of the standard R's implementation of GEE to do the analysis. In terms of actually conducting the trials, so far we have actually all of the interventions that we've run these trials on have been coded in-house. So we're basically developing infrastructure that already has these randomizations pre-programmed in order to be able to study the intervention components. Currently, I'm not aware of any commercial systems that allow you to do this kind of sequential randomization in the way that we have been doing. Although I think there's a need, as the interest in this kind of trial design is increasing, I think there's going to be a need for this, and that I'm hoping some companies will step in and provide an infrastructure that allows researchers to more easily run these studies. But so far we've been doing all of the coding of these systems as well as the randomization in-house.
I have two questions about decision points. Mm-hmm. One, is the information about the decision point always collected passively so that you're not waiting for the respondent to send you or the participant to send you some information through the device before you evaluate what to do at that decision point?
So I think that there are two questions here that are wrapped into one. One is whether the decision point itself is defined through passive means, or it can be user initiated. And the other one is whether the rest of the information that is collected around the decision point needs to be passively detected. So for actual decision, the definition of the decision point, you could in fact have a user-initiated decision point. So a prime example for something like this might be, let's say you have a smoking cessation intervention, and there is a button inside the application where the person can request a coping strategy, and so they're pressing that button could be the decision point at which the randomization happens and you decide what kind of coping strategy to provide. So that can very much be user initiated. Now, whether all of the information that you want to collect at a particular decision point should be passively collected, I think it will depend on the project. Our sense is that we just get much higher quality data if we're able to get that kind of information through passive means. But clearly, that's not going to work for every kind of project. So if you're dealing with interventions in mental health, where most of the both outcomes and potentially some of the moderators would be variables that can only get gotten through self-report, I think self-report would probably be necessary. But we try to get as much as we can through passive means just to increase the quality of the data that we have.
I want to thank you very much for your presentation and for a lively question and answer period. I want to thank our audience for the many questions that they submitted. I'll return this to Natasha to close up.
Thank you, Dr. Murray.
Thank you so much.
And thank you to everyone who participated in today's webinar. As I mentioned at the beginning of the webinar, we will be posting the slides and recording of today's session on our website next week. You will receive an email with a link to the recording when it is available. Thank you.